The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan, and it's a pleasure to be hosting this podcast, and thanks to everyone for listening in. Today, I wanted to tell you a little bit about a 4-part health plan economics blog series that I did recently that you can find at the blog tab at healthcarelabyrinth.com. And we're going to do a couple of podcasts on this health plan economics series. I did do a couple of podcasts back on February 2nd and February 9th on Medicare Advantage. A great deal of what I covered in the first blog about Medicare Advantage was covered already in those podcasts, so I'm not going to do another one related to that. But I am going to probably do 2 or 3 podcasts now related to health plan economics. Today, we're going to talk about the exchanges, when they got created, some of the bumps in the road for the exchanges, and then ultimately how the President Biden today, really put them on a good course, and how the economic or financial framework of the exchanges actually looks very, very good. And so that's what we'll be doing today. We'll be taking a couple of breaks here. One ad will be about the Healthcare Labyrinth website and how to purchase my book. And then number 2, a brand new ad will be about my new company venture that I'm doing with Neetu Rajpal and Alex Schaefer, which is called Lilac Software. It's a data analytics company that we just launched. I'm so happy to be with these 2 partners and launching Lilac Software, and you'll hear a little bit about Lilac Software as one of the ads today. So let's get right to it. So number 1, I want to just tell you a little bit about how the Affordable Care Act started. Now, if we go back in time, back to around late 2000s, a lot of concern about the fact that there was a very high uninsured rate. As you know, our nation does not guarantee coverage as every other developed country does. Every other developed country believes in affordable universal access. Costs are pretty low in those countries. People do pay some into the system, but ultimately everyone is guaranteed affordable universal access, and they get that in one of 3 different systems, either socialized medicine, single payer, or private universal access. So affordable access really for everyone. It's not to say that there are not problems in these countries. There surely are, but the fact is that they have about, on average, a 1% uninsured rate. Here in America, I would say that we have an uninsured rate of anywhere between 8 and 10% almost regularly now. It's gone just below 8% at the peak of the COVID pandemic and liberties taken with eligibility for Medicaid as an example. But I believe that, we sort of have roughly a 10%, uninsured rate, given what could occur moving forward. So 8 to 10%, and that represents somewhere around, let's just say around 30 million people in round numbers are uninsured. But back in the late 2000s, we were at least 45 million. And again, at our best sense, we were in that 25 million range recently. So the Affordable Care Act was passed in 2010, and what did it do? It really did 2 things. One, it expanded Medicaid, and we're going to be talking about that probably at the next podcast. And well over 20 million people have gone into Medicaid because of the Affordable Care Act. And number 2, the Affordable Care Act set up the marketplace exchanges, which was a brand new healthcare form that was set up in addition to the Medicaid expansion. And again, well over 20 million now have entered the exchanges at last count. And so well over 40 million people have benefited from the exchanges. I told you moments ago that we had about 45 million people uninsured. we still have 25 to 30 million. Well, the reason is because there was erosion of coverage elsewhere. But in a general sense, the Affordable Care Act helped us cut our uninsured rate in roughly half. I am a Republican, but I believe strongly in the Affordable Care Act. I think it's the right thing to do. I believe that it was called for. I think we have to make even more strides for affordable universal access. So I applaud what we've done in terms of the Affordable Care Act, not characteristic of most Republicans, I admit. But I do believe that my sentiments actually are what most of the American people think, and that the Republicans in Congress are actually wrong and holding the wrong position here. So anyway, that's the setup to the passage of the Affordable Care Act in 2010, a huge uninsured problem, and again, an expansion of Medicaid and the setup of the marketplace exchanges. Well, the marketplace exchanges went into effect on January 1, 2014. It took about 3 to 4 years to get the marketplace exchanges going. While I admit it had its problems, I think we're on a much better course today. So we'll leave Medicaid for next week's podcast, but let's talk about exchanges and what they really are. So as I noted, they are a marketplace to get coverage, and it's largely by website driven, although you could have agents as well, and oftentimes agents do become part of this process. And there are some problems with that as well, as I will tell you later about fraud and abuse in terms of enrollment. But nonetheless, you enroll in these marketplace exchanges probably by going to a website or perhaps meeting with an agent. And it's really for people who do not have access to other coverage. You're not eligible for Medicare or Medicaid or employer coverage. You can then access the federal exchange or a state exchange, depending on whether a state has taken over the responsibility of running the marketplace in its state. Plans are broken out between roughly 5 types of plans. So there is sort of choice in here. The first one is catastrophic plans, which are largely focused on individuals under 30 years of age. This was to get the younger population into having coverage. In some cases, you can enroll in these plans with exceptions, but generally speaking, they're for people under 30 years of age. The next type of plan is what's known as a bronze plan, and now we're getting into what we call the metal tiers of the marketplace exchange plans. The bronze is probably what we would call the skinniest of the comprehensive plans. And in this case, the bronze plan has to have an actuarial value of 60% of total healthcare costs, not including the premium. So in this case, 60% of costs would be covered by the plan, and 40% would be covered by an individual. Next up is silver, and in this case, the actuarial value has to be 70% of costs, and again, 70% is covered by the plan, 30% by the individual. Gold is next. The actuarial value there is 80%. And then platinum, the actuarial value there is 90%. So that's the metal tiers, the type of benefits. Now, there can be many varieties of bronze and silver and gold and platinum. Plans are allowed to create different types of plans to attract customers. Recently, the federal government has come out with some standardized bronze, silver, gold, and platinum plans, but there is still the ability to offer some custom plans that meet those actuarial levels I talked about. Next, most important aspect of the exchanges and the marketplace plans are premium subsidies. Under federal law, individuals are provided premium subsidies to make access to healthcare affordable on a sliding scale. Under the permanent law, this is for individuals between 100% of poverty and 400% of poverty for their family size. again, it was assumed that people under 100% would be in Medicaid. In fact, the law calls for expanding Medicaid at the state level up to 133, but they did put a stopgap in there at 100%. So as long as you're at 100% of federal poverty to 400% under the permanent law, you're eligible for a subsidy. Now, that subsidy is a sliding scale. It's very rich at the lower end, at the 100 to 150%, and it's not so rich as you get into the middle income level of between 300 and 400% of poverty. In fact, one of my criticisms is that at the low end, you're getting a good benefit, but between 300 and 400% of poverty, and even if you take into account perhaps 250% and up, it's not that friendly in terms of the amount of subsidy you get. For example, if you're between 300 and 400% of poverty, you have to pay nearly 10% of household income before a subsidy kicks in. So nonetheless, a good plan to offer subsidies to buy down the cost of expensive health coverage in America, but it could use additional subsidies in that middle income area. So those are the premium subsidies that are offered under the exchange marketplace. Next, we're going to go to something else called the cost-sharing reduction support or subsidies. And in this case, cost-sharing reduction is another subsidy given to families or individuals between 100 and 250% of poverty. And this subsidy is obtained by enrolling in a special silver type plan. In order to get these subsidies, you have to be enrolled in these special silver plans. And there are three types of plans. One for the lowest range of 100 to 250 is a CSR 94, which means you're only paying 6% of the cost of your plan versus 30% for a normal silver plan. There's also a CSR 87, which means you're paying 13% of the cost as opposed to 30. And then there's a CSR 73, which means you're paying approximately 27% in the higher range between 100 and 250 for your plan. So a slight break on 30%, you're paying 27% of costs. So again, these CSR plans also buy down the cost sharing in your plan along with your premium subsidies, but they're only for people at 100% to 250% of poverty, not up to 400 like the premium subsidies are. Now, there was a premium subsidy enhancement passed as part of several bills, and that temporarily enhanced premium subsidies. There was no enhancement of the cost-sharing reduction, but the premium subsidies were enhanced for 21, 22, 23, 24, and 25. A COVID spending bill expanded these subsidies for 21 and 22, and then the Inflation Reduction Act of 22 expanded these subsidies for 23, 24, and 25, but they do sunset. But in essence, what these enhanced premium subsidies do is really increase across that 100 to 400% of poverty the amount of subsidies that people get. And so up at 300 to 400% of poverty, it's still not as great as I would like to see it. Instead of spending somewhere around 9.8% of income before you get a subsidy, you're spending about 8.5%, a break, but not a big break. But nonetheless, enhanced premium subsidies from 100 to 400%. In addition, for the first time for this temporary period from 2021 through 2025, people over 400% of poverty can also get a subsidy as long as they spend 8.5% of income before the subsidy kicks in. So far we've talked about the metal tiers, the premium subsidies, and the cost sharing reduction. Now I want to touch upon a couple of other quick points. The there are numerous reforms in Obamacare or the ACA that created the exchanges and expanded Medicaid. But one of the most important things in the marketplace exchanges are a couple of things. So number one, the old underwriting system that usually governed these individual types of insurance went out the door in favor of what's known as community rating. Well, underwriting is where insurers look at applicants and can deny insurance, accept somebody, or accept with a higher rate based on the individual's disease states and medical risks. So this is sort of the traditional system that was out there. Now, I will tell you that way back in my career, when I was an executive at a substantially an individual insurance company, I always felt really bad about the fact that I was an executive in charge of essentially underwriting, and that I had to craft policies, and I actually overhauled them to make them fairer. But nonetheless, I was overseeing a plan that actually denied people health care or accepted them or accepted at a higher rate. It was something I did for the business, and it was sort of the law of the land at the time. But I always felt bad for individuals that were being denied. It's not exactly a fair system. That has gone out, as I said, underwriting has gone out, and in the exchange marketplaces, really across the nation, whether you're buying on the exchange or off the exchange is the terminology used, community rating has come in. And community rating is essentially where no one can be denied coverage, and that essentially premium risk is really shared across the entire population. For the most part, people are not paying higher rates based on their medical risk or disease states or things like that. In the case of community rating, there are some rate differentials, and they are based on age, smoking status, regions of the country, because costs can be different across the country, and benefit richness, whether you're enrolling in that bronze plan all the way up to the platinum plan. Even cost based on sexes is blended in age groupings in community rating. So traditionally, a young female who is of childbearing age used to have to pay a much greater premium than a male did. Well, even that maternity cost is blended in age groupings. And I would also note that where age still can have higher charges as you get older, because risk and disease states set in when you're older versus younger, there is a cap on how different those premiums can be at the younger end as opposed to at the higher end. So there's roughly a 3 times cap placed on age-related differences in premiums, and therefore younger people are paying slightly higher rates than they otherwise would have under underwriting, but the folks that are older are paying a little bit less, and it's a little more affordable at the top end because of that sharing of revenue across ages and capping the amount of the differential. Now, many people attack this community rating system. You hear a lot of prominent Republicans arguing it's unfair and it's ridiculous and it has increased costs. Well, to some degree, a very rich benefit in the exchange marketplace has increased costs. I believe that. And I think perhaps over time we should look at the richness of the benefit. But the truth is that, the increases in premiums are not really unreasonable to have and related to community rating versus underwriting. And the reason I say that is because employer coverage, which is the lion's share of coverage in America, has practiced community rating for decades. If you enroll in an employer, you cannot be denied coverage. And essentially, all of the risk of individuals is spread out among the entire company. People are not being charged more if they're older versus younger, if they're male versus female. Rates are set, and employees are charged their share, and employers are charged their share in employer coverage. And so we effectively have community rating in the employer world. And that, again, is what has been there forever. Why we had underwriting for the people that were perhaps the most vulnerable and did not have access to employer coverage really didn't make a whole lot of sense. So I sort of dismiss the attacks on community rating and how it may have driven up costs dramatically. I don't think it really has. I do admit that there are some increased costs because of benefit richness and mandates and things like that. And perhaps we could look at those maybe in the future. But generally speaking, the attacks on the ACA for community rating are really not reasonable. A couple of other areas I'd like to touch on before we take our first break. No one can be denied insurance now under the law for pre-existing conditions. And more importantly, all pre-existing conditions are covered by the insurer or the employer group, and no waiting periods can apply. So that protects individuals with disease states as well. In my blog, the Health Plan Economics Part 2, published on April 29th, you can read a little more about the percentage of federal poverty level, when premium subsidies kick in from 100 to 400% or more, when the enhanced premium subsidies kick in and what those rates are, and the permanent cost sharing reduction subsidies are also listed in the table. So if you want to go to my April 29th blog, you can look at that table that explains everything related to federal poverty level, the permanent law premium subsidies, the enhanced premium subsidies, and the permanent cost sharing reductions. And so you can look right there for more information about this. So this time we'll take our first break, and we'll be back to just give you the history of Obamacare over the last 14 years or so. We'll be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We've been talking about the exchanges and some of their setup, and now we're going to talk a little bit about the history of the exchanges. Well, unfortunately, there's sort of some bad news here, but I will say that we are on the road to financial stability. Back in 2014, when the exchange marketplaces launched, it was very, very rocky, I have to admit. For many years during that early period, I would say that both the Obama and the Trump administrations put major roadblocks in front of the success of the program. And this is despite Obama really being the father of the law. So it was quite interesting to see some of the policies that came down from the Obama administration. So again, the start of the program was very rocky. Few understood it, and marketing and outreach did not work very well. What's more, the launch of the enrollment website, which is the key way of enrolling people, was horrendous, and many lost faith in the program. So there was very, very low enrollment in year one, just 8 million people, far below what was projected enrolled in the program in that first year. Now, in the first 3 years, there were some important safeguards that were passed to ensure the financial success. And essentially, the financial system in the exchange was anchored on what is known as the 3 R's: risk adjustment, reinsurance, and risk corridors. So risk adjustment is a permanent feature of the exchanges, and that was meant essentially to transfer revenue between plans that had beneficial selection, people were healthier, versus those plans that had adverse selection, where people were sicker and had higher costs. So risk adjustment is something that is used to transfer those dollars between plans to ensure equity in terms of the premium and the risk of entire populations in a health plan. So that permanent feature lives on today and works pretty well. The other two financial safeguards that were in the first 3 years was what were known as reinsurance and risk corridors. Reinsurance, in essence, was fees charged to insurers that funded a pool that then transferred dollars to plans that had catastrophic claims in those first 3 years. So, in essence, over a certain threshold, you would be paid from that fund that was supported by levies on health insurers to essentially alleviate some of those very high catastrophic costs that were seen in the first few years, because many people were getting into insurance for the first time and they had some major health conditions. There was also a program that was temporary for the first 3 years called the Risk Corridor Program. And this looked a little bit like risk adjustment. In the first 3 years, at the end of each of those years, risk corridor payments were again made either up or down. If you did very well in the program, some of your revenue was taken back by the federal government and shuttled to plans that did not make out very well in terms of a bottom line for all sorts of factors. So this, again, these three programs, risk adjustment permanently, and the reinsurance and risk corridor program, which were temporary for the first 3 years, was meant to take away some of the risk for insurers as the nation transferred from rates based on underwriting to that modified community rating we talked about before the break. And so, in essence, what happened during the Obama and Trump years is that the federal government did not fund the reinsurance or the risk corridor programs appropriately. Reinsurance a little less so in terms of adequate funding, but risk corridor funding was just abysmal. They did not assess the right fees on plans, and therefore many plans that saw large catastrophic claims or did poorly financially in terms of the first 3 years did not get paid the amounts that they should have in the program. And frankly, the Obama and Trump administrations really didn't do anything about it. So those that did very well made out like bandits, and those that in good faith went into the program based on full funding of the reinsurance and risk corridor programs were left holding the bag. This meant that many plans exited the market, the exchange marketplace, because they lost faith in what the government was doing. This had a huge impact on premiums, the number of plans in each state, network coverage in states. A network coverage was pulled back if a plan even remained in the program, as well as access by individuals to the physicians they really needed. So it was a very, very poor financial policy decision by both administrations. They should have found a way to fully fund it. We're on a national experiment, and yet they did not. They just sort of let it roll out the way it did. And again, plans lost faith. To make matters worse, the Trump administration did even more things that really destabilized the marketplace exchanges. When Trump came into office, he immediately reduced outreach and marketing dollars. He also restricted open enrollment periods. But most importantly, he defunded the cost-sharing reduction subsidy appropriation. He and the GOP leaders in the House at the time and the Senate believed that these were sort of giveaways to health plans and things like that. They hated in general the exchange program, and they basically went after this cost-sharing reduction subsidy appropriation. Because plans under the law still had to offer cost-sharing reduction plans, What had to occur is the plans had to build the offering of the reduced cost sharing plans into silver premiums. And therefore, those silver premiums increased dramatically for calendar year 2018 and on. It was really an absolutely foolish move by Trump and the Republicans in Congress, because in essence, the increase in premiums and what resulted in obligations of the federal government to fund the premium subsidies for silver plans actually was higher than the cost sharing reduction appropriation that was historically in there. So the government was now spending far more dollars. Silver premiums and other premiums went up dramatically because of this move by Trump. And what really happened was many of the poorest people did not really see a major change because their premium subsidy, had to go up dramatically as well. It's really those middle class people again that were hurt because they could no longer afford sort of having insurance when they got very little, or especially if they got no subsidy at all. So overall, if you take the track record of the Obama and Trump administrations together, it really led to an erosion again of plans in the system, network access and offerings in the system. And therefore, really, until President Biden came to office and could impact policy, you had a program that pretty much bumped along. We told you that the 2014 enrollment was about 8 million related to just the poor rollout. In 2015, there was about 11.7 million people in the exchanges, still very low. It peaked at about 12.7 million in 2016 before some of this fallout on the 3Rs came up. It dropped to about 11.8 million when we had the debacle from Trump over the funding of the CSR subsidies. And into 2019 and even into 2020, only about 11.4 million people were enrolled in the program. And the silver average benchmark premium really increased from about $273 per month all the way up to $462. So big major increases in premiums and loss of access and loss of the number of plans in the system. So the average number of marketplace insurers per state began at about 5 and improved a little in 2015 to 6, but by 2020, the average number of marketplace insurers had dropped to 4.5, again, because of the loss of faith in the program, in the running by the federal government. So all around, up through 2020, things were not very good in the marketplace exchanges. Let's get back to the Biden administration, however. And the Biden administration really came in and actually cleaned up a great deal of things when President Biden came to office. So what exactly did President Biden do? Well, number one, he immediately came in and reinvigorated outreach and marketing dollars for the program to explain what it was and why you should enroll and obtain coverage. And he returned to more liberal open enrollment and special enrollment periods. In addition, he won passage again on 2 occasions of the enhanced premium subsidies we talked about earlier. Again, one in 2021 as part of the COVID relief bill, and those enhancements were for 21 and 22, and again in the Inflation Reduction Act of 2022, and those enhancements were extended for 23, 24, and 25. So just all of this attention to the exchange marketplaces meant great things for enrollment, and even in terms of plans coming in, better network footprints, better access to physicians, as well as benchmark premiums. So in 2021, because of his work, Premiums actually dropped from $462 for the average silver benchmark premium to $452. As of 2024, the rate of the average silver benchmark premium went up to $477, but you can imagine the difference from 2020 at $462 to 2024 of $477 is really de minimis. So premium stabilized. The amount of individuals that enrolled in the exchanges jumped dramatically. In 2020, there was 11.4 million enrollees, as we told you earlier. By 2024, there were 21.4 million people enrolled because of the better approach to the exchanges. And we told you also that the average number of marketplace insurers per state had dropped to 4.5 in 2020. Well, in 2024, that grew to a record high 6.0. So that's a pretty amazing accomplishment for President Biden after everything that had occurred with the exchanges in the first many years of its adoption. So from an economic standpoint, what does all this tell us? Well, insurers were simply looking for predictability from federal regulators. The controversial launch of the exchange program, combined with short funding in some of those key financial protection programs, meant low enrollment, insurers bailing on the program, and numerous plan participation and network access issues in many states. As such, after its terrible start in 2014, the program again bumped along between 11.2 and 12.7 million enrollees, and as low as 3.5 average number of plans per state because of all the uncertainty from regulators. But beginning in 2021, with a vigorous endorsement by Biden, as well as the enhanced premium subsidies, enrollment surged, as did the number of plans in the program by state. Contracted offerings, network, and access all stabilized. Geographic penetration looks so much better. In fact, with larger enrollment and less risk, premiums are pretty stable right now, having come down after the CSR debacle in 2018 and only moderately increased since then. Opponents, again, like to attack the ACA for driving up costs. And, I want to set aside the philosophical debate about whether the yield should get coverage through community rating. I think they should. But even if you look at the program holistically, the fact is that average silver benchmark rates are only up by about 75% in 10 years, or 7.5% per year. Admittedly, that's very healthy, but it's certainly not the outrage that the opponents talk about. What's more, you really need to adjust the impact of Trump's and the GOP's defunding of the cost-sharing reduction appropriation as of 2018 and beyond. I have assumed that about 60% of that 2018 increase is due to Trump's defunding of the CSR. If you take that away, the increase over 10 years in average silver benchmark premiums is just 48%, or 4.8% per year on average. Again, that is robust inflation, but certainly nothing extraordinary, especially given all the turmoil in the program. And since enrollment has increased dramatically during the Biden years, the average increase is below 2% per year. So to me, that's really the truth around what's happened in the exchanges over the last 10 years. What we're going to do now is take our last break and come back and talk a little bit about what likely would happen if the enhanced premium subsidies lapse.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we're going to just sort of sum up some things here. We've talked a lot about underwriting versus community rating. I think you know that I believe that the community rating system is fair. And again, the employer-sponsored coverage system has been based on community rating in essence for decades and since employee coverage came out. I do believe that perhaps you can make a case, as I've alluded to, that benefits in the exchange are a bit too rich and some of the mandates across the board are a little high. Over time, I think some of the coverage areas and scope could be looked at. It does drive some costs in the exchanges, but also in other coverage where ACA mandates preside. So we should look maybe at that in the future. I will tell you, though, that I'm a big fan in the free preventative services because I think it's really key to help identify disease early when it is cheaper to treat. On the issue of subsidies, I am of the mind that at the low end of the income range, with these enhanced premium subsidies, and even perhaps in the permanent law, we are a little too generous right now. And we are not generous enough at the high end of income, even with the enhanced subsidies. But I'm also a pragmatist on this issue. The enhanced subsidies have worked to really drive coverage in a big way. So whether I think they're too generous at the low range or not really doesn't matter. The enrollment figures really suggest that the change was important to drive enrollment and get people coverage. Yes, some of it may be due to the Medicaid redetermination. Some of that increased enrollment may be due to the loss of Medicaid coverage, but it's clear that a very good share of it is tied to better subsidies as well. So it's somewhat hard to mess with success. So on balance, I would tend to agree that the subsidies should be made permanent, the enhanced ones. And even the subsidies from 250% on up, in my mind, should be looked at to be made even richer to promote middle-class coverage as well. So what would happen if enhanced premium subsidies lapsed in 2026? Well, health plan economics, frankly, would kick in. The number of people enrolled would fall dramatically. That alone could create financial issues for plans in terms of revenue and margin. Premiums would likely increase. A compelling case, too, could be made that the sick will retain coverage if that were to happen, while the healthy abandon it. That creates what is known as adverse selection, and insurers would need to take that into account. That would send premiums up even more. What's more is that the number of insurers participating, the average number of plans per state, and therefore choice and network adequacy would likely suffer. We would likely return to the plan participation levels seen prior to premium enhancements. That would create issues in many states that have only recently seen plan participation rise. The number of counties with just one or two insurers would surely skyrocket. In conclusion, we all can argue that the ACA can be improved, but now is not the time to jeopardize the progress we have made on coverage. We are already going to see the uninsured rate rise due to many losing Medicaid coverage. We cannot afford to see exchange rolls drop as well. While I am not opposed to some tweaking of the premium enhancements, to me the wiser move would be to leave them where they are, or perhaps be a little more generous at the high end for at least 5 more years. Perhaps then a consensus can be built on healthcare reform and the benefits, subsidies, and more can be revisited. The most important thing that I want to point out here is that the exchanges have provided consistent upfront coverage for millions of people. And that is far better in terms of cost than if these individuals were uninsured and accessing high-cost healthcare settings like inpatient and emergency rooms to get their basic care needs met. It just makes absolutely no sense. And that's why affordable universal access ultimately is where the nation needs to go. With that, we'll end this edition of the Healthcare Labyrinth Podcast. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.